Hello, friends. Hope you are all doing well. I'm Dr. Amrit Nasta, your surgery educator, and today we will discuss some more questions that I shared with you on Telegram and also the way you guys performed. Now, if you have not watched my previous video, please watch it and please follow me on Instagram and subscribe to my YouTube channel. And let me share with you the outcomes and also discuss these questions. All of these questions are made by me. You may not find them in a lot of Q banks, but you'll realize these are on topics which we feel we know very well. But when a tricky question comes, how we make mistakes and how should we be analyzing these kind of questions. So this also covers upper GIT. So let's start with the first one and let's see how you guys fared. So which of these is incorrect about achalasia? Proximal esophagus shows ineffective peristalsis. This is true. There are two things that you're supposed to see in achalasia. The first one is you will get weak peristalsis in the body. And the second thing, of course, you should know is a tight lower esophageal sphincter. So this is correct. Heller's myotomy is ideal for all types of achalasia. Now, you know, Heller's myotomy, they cut the muscle of the lower esophagus and the cardia of the stomach so that it opens up and then the pathway of food becomes better. But is it ideal for all types? This is false. All right. Heller's myotomy is not ideal for all types. It works well for type 1 and type 2 achalasia. For type 3 achalasia, OM or oral endoscopic myotomy is preferred. All right. Type 3 achalasia, which is also known as spastic achalasia. So this has come in a lot of entrances about what are the different types of achalasia, Chicago classification of manometry. If you don't know the types, at least know that for type 3, that is spastic, the treatment is POEM. Epiphrenic diverticula are seen. Yes, they can be seen. Epiphrenic means above the diaphragm. So it's simple. If the lower esophageal sphincter is going to be tight in achalasia, because of the tightness, the mucosa on top, just above the LES, can have an outpouching, which will give you epiphrenic diverticula. So that is correct. And yes, of course, weight loss is going to be more common than weight gain because these people suffer from dysphagia. So weight loss is going to be more common. A severity score used in achalasia is called Eckhard severity score. Please make a note of this if you haven't already. Right, that is called Eckhard severity score. So that was the question. Just see how many people got it right. Okay, just not even a third of the people who attempted it. Let's move on. Which of these is correct about hiatus hernia? All right, the question asks which of these is correct. Hiatus hernia means esophagus or stomach are herniating through the esophageal hiatus into the thorax. Best seen on upper GI scopy. This is false. Remember, hiatus hernia are best seen either on CT with oral contrast or barium swallow. Obviously, in today's day and age, the answer will be CT. So if you have to pick one, go for CT, not an endoscopy. Endoscopy may miss a hiatus hernia. Mixed type involves upward migration of GE junction. This is the true statement. So basically, it is the sliding type. Okay, the sliding type of hiatus hernia is the one where the GE junction migrates into the thorax, but also the mixed type, because what is the mixed type? Mixed type is nothing but where there is a combination of the sliding and the rolling paraesophageal hernia. So obviously, even in the mixed type, which has the sliding component, the GE junction will be migrated upwards. Rolling type is commonly linked to GERD is false. It is a sliding type. And surgical management is not rarely required, it is mostly required. Because hiatus hernias will worsen GERD. So here again, see how many people got it right? Barely 42% people. What I'm trying to tell you is these topics we feel we know in and out, but unfortunately we don't. Now look at this question. A very standard, very straightforward question. 50-year-old male with history of alcohol presents with vomiting of blood. Vomiting of blood means what? He presents with hematemesis. And which of these is the least likely etiology? Basically, which of these is unlikely to cause hematemesis? Mallory Weister obviously is going to cause, but 40% people marked it as true, which is strange. Mallory Weister does present with hematemesis. Maybe people misread it. So, you are hurrying through the question and you misread it, you misunderstand it, and it's a silly mistake. Gastritis can cause, esophageal varices, of course, can cause. Boerhaave syndrome is going to cause esophageal perforation. It's not going to present with upper GI bleed or hematemesis. This will present with macular striate, right? This will present with macular striate. And what is this macular striate? You get chest pain, you get vomiting or retching, and you get subcutaneous emphysema, which is a feature of Boerhaave syndrome. So Boerhaave is esophageal perforation, not hematemesis. Okay. This was another simple question. Which of these deficiencies is typically seen? Most of the times, even if we just read the question correctly, a lot of the silly mistakes will be avoided. Which of these is typically seen in blind loop syndrome? Blind loop syndrome means there is a segment of small bowel which is either aperistaltic, so it is having no peristalsis, or it is excluded, means food is not passing through it, it is excluded. Being a bariatric surgeon, I can tell you this is something that can happen in a surgery which we perform very regularly, which is called as Roux-en-Y gastric bypass. But yeah, any kind of intestinal bypass, you can get a blind loop. But what are they asking you? What deficiencies is seen? Typically, now when there is a blind loop, there is a segment of small bowel which is excluded, but it is not resected. There can be a small intestinal bacterial overgrowth, also called as SIBO. And because of these bacteria growing in the small bowel, remember, small bowel does not have bacteria, bacteria are in the colon. If you have bacteria in the small bowel, they will use up your B12 and you get B12 deficiencies. That is one of the typical things, vitamin B12 deficiencies. Conventionally, when we study MCQs in surgery and we talk about anemia or we talk about nutritional problems, it's always going to be iron deficiencies. This is the rare scenario where B12 deficiency is more common. Okay, so because of this bacterial overgrowth, we are going to get B12 deficiency. Now take a look at this. Goodsol rule, something we often fail to understand in a fistula and ANO. I will put it in a very simple way. All right. Now, what is this Goodsol rule? It's a rule for fistula and ANO. And this rule helps me predict how the course of the tract is going to be by looking at the external opening. So if I see the external opening, I can predict where the internal opening is going to be. So how do I predict this? I draw a horizontal line from the anal canal at the anal verge. All right, and this is anterior. This is posterior. All right, this is the scrotum. So we are looking in the lithotomy position. And I make a semicircle at 3 centimeter radius like this, anteriorly. Okay, this is a 3 centimeter radius semicircle anteriorly. Now, what do I need to see? I need to see the external opening. All right, if the external opening is within the semicircle, so within 3 centimeters anterior, the tract will be straight and it will open in the same line. So straight tracts are going to be anterior. Just remember this. Anything outside of this semicircle, whether it is anterior more than 3 centimeters, if it is over here, or it's a posterior, let's say over here, anywhere outside this semicircle of 3 centimeters anterior, the tract will go posterior and open in midline. All right, so anywhere beyond this, the tract will go posterior and it will open in midline at 6 o'clock. Now see the question, external opening is 4 centimeters anterior. So where will the tract go? Posteriorly at midline. How many people got it right? Basically everybody is confused. You can see if you get 20-30% and for response, that means everybody is confused. But let's keep it simple. Within 3 centimeters anterior, it will go straight anterior in the same line. Anything outside this, whether it is anterior or posterior, it will go posterior in midline. Okay, midline means 6 o'clock. So now I hope Goodsol rule is well understood. This was one of the few questions which I got a good correct response. There is a 4-week-old child who has repeated non-bilious vomiting. So a child who is a 1 month, 1.5 month old with non-bilious vomiting is having infantile hypertrophic pyloric stenosis, right? And you can see sodium seems all right, but potassium is low, less than 3.5. So there is hypokalemia, there is alkalosis, which is what is expected. So you expect hypokalemia, you expect hypochloremia, you expect alkalosis. You also expect aciduria paradoxically. So what fluid will you use in resuscitation? It is going to be DNS plus KCl. In children, you will prefer dextrose containing fluids. He is hypochloremic, so you have to give saline. And for hypokalemic, you have to give potassium separately. So it is going to be DNS plus KCl. In children, it is going to be 0.15% KCl. This is the answer given in Bailey. Okay, this is the answer given in Bailey. DNS plus 0.15% KCl. Okay. Another topic which I feel students don't really understand. When I say D2 lymphadenectomy, all of these lymph nodes are going to be removed except. So it's very simple. What is D1? What is D2? What are all these lymphadenectomies? When I say D1, D1 means I'm going to remove lymph nodes around the stomach, which is called as perigastric lymph nodes. What are perigastric? You can start from here. This is station 1. This is station 2. Left and right, paracardiac. Station 3 is on lesser curve. Station 4 is on greater curve. Station 5 is suprapyloric. Station 6 is subpyloric. This is my perigastric. All right. So this right cardiac is going to be station 1. So this is obviously included in D2 lymphadenectomy. Now when I say D2, D2 means D1, that is perigastric, and lymph node stations along the blood vessels, along the major blood vessels, that is along left gastric artery, along hepatic artery, along splenic artery. So these are the arteries which supply the stomach and the branches, and celiac. All right. So along these trunks, the lymph nodes are going to be removed. So anterior hepatic, yes. Celiac, yes. Hepatoduodenal, no. This is the correct answer. Hepatoduodenal is going to be removed in D3, which is not commonly done. So what you need to know is what is D1, D2. Anything outside it is going to be D3. That is going to be the lymphadenectomy for CS stomach. Another very nice, tricky question. You can see how the responses were. Which of these is incorrect about Crohn's disease? What I try to do, when I make these questions, I try to divide the options such that each option seems interesting. Each option should entice you. That's a good MCQ. If there is any option where the response is 0%, that's a bad question. That's the bad option. So, which of these is incorrect? Multiple perianal fistulae occur. Yes, they can occur. Perianal Crohn's is known. In ulcerative colitis, you don't get perianal fistula. The risk of colorectal cancer is similar to ulcerative colitis. This is false. The risk of colorectal cancer is much higher in ulcerative colitis. The reason being, ulcerative colitis starts in the rectum, spreads into the colon. So rectum and colon are technically always involved, and it's a chronic disease. Crohn's disease typically starts in the ileum, terminal ileum, some parts of colon, some parts of perineal. So it is going to have skip lesions. The risk of cancer is relatively less. If you didn't get this, the other options seem clear. Sulfasalazine shows no benefit in ileitis. This is also correct because understand sulfasalazine gets activated in colon. You may have studied in your pharmacology. It gets activated in colon. So if it gets activated in colon, it will not help in the ileitis. It will have anti-inflammatory effect only in colonic Crohn's. Okay, that is why sulfasalazine is more beneficial in ulcerative colitis because that is a purely rectal and colonic disease more often than not. Surgical resection is kept at a minimum. This is true because there are skip lesions. So if you keep resecting every part, there is a risk of short bowel syndrome. Right? The person is at risk of short bowel syndrome. Right? So that was simple. I hope you got this right, but only 41% got it right. Another trick question, just see the responses. You always felt acute appendicitis, piece of cake, you can never get it wrong, but just see the responses. And almost 200 people have answered. So what is the mismatched finding in acute appendicitis? This you should have actually gotten right by yourself by elimination if you didn't know the correct answer. Bloomberg sign or Blumberg sign. This is the sign which is called as rebound tenderness. So it's like a rebound tenderness. What is this rebound tenderness? When you palpate in the right iliac fossa and when you release, the person gets a sharp pain. So this is correct. I don't know why 30% mark this. Psoas sign pain on hip extension is also correct. So sometimes in appendicitis, if it's a retrocecal or a pelvic appendix, it irritates the psoas muscle. If it is resting on the psoas muscle, it will cause psoas spasm. Now, psoas is a hip flexor. So when there is a psoas spasm, the hip is going to be preferentially flexed. Hip is preferentially flexed because psoas is a hip flexor. So when it's spasmed, it will cause hip flexion. So if I extend the hip, he gets pain. So this is correct. All right. Diarrhea in post-ileal appendix. Now understand, if the appendix is post-ileal. Post-ileal means it is very close to the ileum. Normally appendix is retrocecal like this. But if by chance the appendix is post-ileal and it's inflamed, if it is inflamed, it will cause inflammation of the ileum or ileitis by contact, which will lead to ileal diarrhea. On the other hand, this last line, this is a line from Bailey. Okay, this is a line which is given from Bailey. Rigidity is rarely going to be seen in retrocecal appendix. Okay, it is rare. Rigidity is rare. Please be very clear about this. This is the line given from Bailey, 28th edition. The reason being, if my cecum is over here, and if the appendix is retrocecal means behind the cecum. And if it gets inflamed, the cecum is in front. So it will not let the appendiceal inflammation reach the anterior abdominal wall. Thereby, the rigidity or the guarding may be a little masked, especially if the cecum is loaded with gas. All these are words from Bailey. Now, I don't expect you to read Bailey if you are appearing for entrances, but definitely if you are an MBBS student, these are the things you should be knowing. All right. And which of these is incorrect about Meckel? This was another very easy question. I can't believe the responses I got. More were wrong responses. In children, it presents with features mimicking appendicitis. Now, let's be clear. In children, if it is manifesting, it will manifest with ER bleed. All right. Otherwise, it will not manifest in children only. And why does it manifest with PR bleed? That's because of ectopic gastric mucosa. So Meckel's is known to have ectopic gastric mucosa. And these gastric mucosa in the diverticula are going to produce gastric acid, which will cause ileal ulcers and PR bleed. Now, why children? Why not in adults? In adults, it mimics appendicitis. The reason being, if there was gastric mucosa, it would cause bleeding at a very young age, not in an adult. So the fact that it has reached adulthood means there is no gastric mucosa, means there is no ectopic mucosa. So obviously in an adult, if there is no gastric mucosa, that means it will mimic appendicitis or it will be found incidentally. So this was the answer and only 17% people got it right. It commonly arises from the ileum. It does. It is also called as diverticulum ileus. It's an ileal diverticulum, 2 feet proximal to IC junction. That is ileum only. So it is 2 feet proximal to IC junction. But that is going to be ileum. It's not jejunum. Technetium scan is used in bleeding Meckel. This is true. So in children who have bleeding Meckels and you want to localize ectopic gastric mucosa, you can do technetium scan. Incidentally found Meckels can be left alone is also true. You may consider excision only if it is narrow based. If it is broad based, it can be left alone. All these are lines from Bailey. Right? And the last one, the most easy one. Okay, this was the most easy one, which also a lot of people got wrong, is which of these is a type of closed loop obstruction. Closed loop means there is a blockage at 2 points in the bowel. So their entry point, exit point, both points are blocked. The part in between will distend, it will become ischemic, it will explode. This is a dangerous condition. So best example of a closed loop obstruction is a volvulus, like a sigmoid volvulus. Because when there is a volvulus, a twist, so entry point, exit point, both are blocked because of the twist like this. But obviously I did not give that in the option. I gave the option which is there in a diagram in Bailey. There's a picture of this in Bailey. So gallstone ileus. Gallstone ileus means gallstone has gone in the small bowel and from there it is blocking the terminal ileum. So this is a mechanical obstruction at the ileum. This will cause ileal block. So there is a block only at one point. Intussusception will cause a block at IC junction if it is an ileocecal intussusception, the one which is seen in children. 1 point block. Richter's hernia, so there is no obstruction in Richter's hernia. In fact, it is one of the hernias which will strangulate without getting obstructed. You know, that's the famous saying, because only a part of the bowel wall is in the sac. So in a Richter's hernia, only a part of the bowel wall is covered by the defect. So if the defect is covering over here, only this much part is in the defect. So only this much part can get strangulated. The rest of the bowel is fine. So it will get strangulated without getting obstructed. So by elimination, you could have gotten the answer obstructed CA transverse colon. But why is it blocked at 2 points? It's very simple. Understand, there is a ileocecal valve over here, which prevents the colonic contents refluxing into the ileum. So in a normal person, whatever is the colonic content, even if there is a problem in peristalsis, it cannot go back. Okay, there is a block over here physiologically in a normal person. Now, on the other hand, I am telling you that there is a carcinoma in the transverse colon, means over here there is a tumor. It is causing a block over here. So you have one block over here and other is the physiological block. So entry point, exit point, 2 points are blocked. So this becomes a closed loop obstruction. All right, the same thing is given in Bailey, but we have to apply the fundamentals, only then the MCQs will get solved. So my main message to you in this is, and this is the second video I'm having on Telegram Q banks, is a lot of topics we feel we know very well, but unfortunately we don't. It's because we don't practice enough. So till you don't practice solving from whichever source, whichever app or textbook or MCQ book you are using, you have to practice, practice, and practice. That's the only way of cracking entrances, and that is the only way of understanding that you really know a topic or not. Otherwise, you will feel you know very well. Actually, you don't. When it comes to the exam, you will make mistakes, right? So if you enjoyed this video, please like the video. Please subscribe to my YouTube channel. You can follow me on Instagram or Telegram, where I keep sharing these kind of questions. So the learning journey should continue. Thank you for joining me, guys.